So, hello and welcome back. I'll be discussing a logical approach to chronic inflammatory diarrhea, and this will be our first video on the general larger series on approach to chronic diarrhea, the first part of the series. Now, let's unpack this a little bit. What do I mean by a logical approach to chronic inflammatory diarrhea? Okay, so logical is self-explanatory, but the rest of it needs a little bit of unpacking. So when I say chronic diarrhea, I mean diarrhea that is lasting more than or equal to 4 weeks. This is again one of those symptom specific definitions. Then when I mean inflammatory, what I strictly mean is actually the presence of more than or equal to 5 WBCs per high power field in the stool. That's what I mean. Okay, so this is literally nothing to do with the actual immunopathogenesis or the histopathological changes that are occurring in the wall per se. Okay, it's a really reasonably specific investigational finding. Now, having said that, essentially there is only one disease that fulfills this criteria. That is inflammatory bowel disease. They're having okay, so I would get a little bit of pushback for this, but there are others. For example, you can get subclinical colitis in obviously our SPA, spondyloarthritis spectrum disorders. Okay, you can get colitis in Behçet's disease, right? But these three entities at a pathophysiological level are essentially the same. It is just us, rebranding them depending on the context, and we'll get to that when we talk about Behçet's disease. Then there are chronic infections that can cause chronic inflammatory diarrhea. Okay, but actually, there's only one that truly does cause this. So that is your tuberculosis, which obviously will warrant its own discussion. Now, there are intestinal lymphomas or malignancies that can present like this. A very specific one is what is called Seligman's disease, or your immunoproliferative small intestinal disease. Okay, so this will be covered on the broad section on plasma cell dyscrasias, but this is not true inflammation. Okay, it's just inflammatory diarrhea, as in you get more than equal to 5, you may get more than equal to 5 WBCs per high power field. So essentially what I'm trying to get at is that when I say chronic inflammatory diarrhea, the main entity that we're talking about is IBD. Okay, also to some extent in the right clinical context, subclinical colitis with spondyloarthritis, and actually I could argue that they are the same disease. And again, the differences between IBD, particularly Crohn's variant of IBD, and Behçet's disease are technically just lines in sand. Okay, so there is a lot of overlap there in terms of pathogenesis, and that will come to at the end of the discussion, and again when we discuss Behçet's in the future. Okay, so let's go ahead and play out the structure of the talk. So I'll be discussing this with the following questions in mind. The first question will be, IBD, that is inflammatory bowel disease, essentially is the only true cause of chronic inflammatory diarrhea, and this is something that I've made quite clear already. Okay, I'll elaborate on this using the pathophysiology of IBD, and I'll explain why the normal intestinal tract is actually, in a sense, immune to, I shouldn't use the term immune, is not usually susceptible to unnecessary inflammation. Okay. Second thing is, what determines the observed patterns of distribution of inflammation in inflammatory bowel disease, both variants, and we'll find that, and we'll try to deduce that using our understanding of immunopathogenesis. Then how would this perturbation in normal intestinal physiology result in clinical symptoms? Because we've already discussed previously that clinical symptoms are just abnormal physiology. Okay, so a person's normal physiology is we're getting affected in a certain way, and therefore they're presenting with a particular symptom. Okay, so we're going to work our way back so that when we see patients, we can work our way forwards. Okay, now after that, can these processes occur outside of the intestinal mucosa? As in, can they extend from the intestinal mucosa outside, or occur independently at a different site because of common immunopathogenesis or underlying genetics? If so, how exactly? And I'll be enumerating the causes here. In the next discussion in this series, we'll be talking about the exact mechanisms and how they play out in each individual extraintestinal tissue. So I wanted to highlight that separately. So though that it traditionally is taught as the extraintestinal manifestations of IBD. And finally, what are the external risk factors that predispose a given person to IBD? So obviously everybody doesn't develop IBD. So what might be the external risk factors? Actually, this is the general format that I use while discussing any autoinflammatory autoimmune disorder. It is a systemic autoimmune rheumatic disease. And once we get into a series on discussions on the actual illness scripts of systemic autoimmune rheumatic disease like SLE, RA, systemic sclerosis, Sjogren's, at that point we will be following a very similar pattern. We will understand the immunopathogenesis, then deduce the clinical features as well as the risk factors from that. Okay, so let's dive right into it. So this is the normal intestinal mucosa. The normal intestinal mucosa consists of epithelial cells that are attached to each other by tight junctions, and overlying it is there a layer of mucus, a very smooth uniform layer of mucus. Okay, actually there are bacteria in the lumen of the intestine that is in superficial, in this case, to the mucosa, that is separated from the epithelial cells by the mucus layer. Okay, now how does the normal, now the thing is, everybody obviously eats, and when you eat you are ingesting a lot of foreign antigens. Okay, and as we've discussed previously, exposure to foreign antigens is what causes innate immune activation, okay, and subsequent adaptive immune activation. But that doesn't happen when you ingest food items, and that is what is called oral tolerance. And oral tolerance is a rather interesting physiological mechanism, okay, that needs explanation, as in how is the immune system being in a way controlled from reacting to these external antigens. So let's see how that happens. And again, this is us making our way through how the immune system functions at these barrier sites into a deeper understanding of actual immune physiology and pathophysiology at a later stage. So let's see what's happening. Now I've enlarged a epithelial cell, and you can see the epithelial cell internalizes or endocytoses some bacterial product. Now it does so using two proteins. The red protein here is a protein known as ATG16L1. Okay, and the green protein is our familiar NOD2, which is a NOD-like receptor. Okay, now ATG16L1 essentially traffics this endocytosed bacterial product into a phagosome, okay, and or an endosome, and that endosome is then through a process called autophagy. Autophagy basically means to eat oneself. So cells clear up debris or various organelles that are not functioning properly using the process of autophagy. Okay, now during this autophagy, the protein components of this bacterial product are cut up into multiple parts by a proteasome. Okay, and that proteasome is used to produce a 8 to 12 amino acid long small polypeptide chain. Okay, that polypeptide chain is then expressed attached to a class 2 MHC molecule like this. Okay, this is the polypeptide and this is the class 2 MHC molecule. Now that is recognized by, as would any other MHC molecule, by T cells. Now the thing is, the T cells that are activated here, the T cells, are not they polarize to a T regulatory subset polarization. So T regulatory cells are naive CD4 T cells that have started expressing a transcription factor called FOXP3. Okay, and in addition to that, run X3, and because of that, they have become cells that primarily produce interleukin 10 family interleukins. Now, interleukin 10 is a anti-inflammatory interleukin. It signals to surrounding cells that there is no need to panic, there is no need for immune activation, and therefore it prevents inflammation from happening. So a steady stream of metabolites from the lumen of the intestine through the epithelial cell in this process ensures that a population of T regulatory cells is maintained within the normal intestinal mucosa, okay, preventing unnecessary aberrant immune activation. Now, additionally, there are a specific subset of dendritic cells of tolerogenic, that promote oral tolerance, dendritic cells that are specifically positive for CD103 and another protein called fascin, okay, that also produce TGF beta, and TGF beta in turn causes T regulatory cell polarization. So both of these cells in concert with each other induce T regulatory cell polarization. And then what happens is that the T regulatory cell produces interleukin 10 and more TGF beta, and that is what is responsible for our oral tolerance. Now, the epithelial cells also produce interleukin 1 family cytokine called interleukin 33, and we'll be coming to this later, but this is essentially an anti-inflammatory cytokine from the interleukin 1 subfamily. Okay, so again, that promotes oral tolerance. And there are some regulatory innate like lymphocytes also which produce IL-22, and I told you in some context IL-22 maintains epithelial function normally. Okay, in the previous discussion on our skin, the function of skin, we discussed this. Okay, so this is like a four front attack, or a forefront, or a table that is rather the analogy, a better analogy would be a table that has got four pegs, or four pegs on which it is balanced. So the thing is, this gets perturbed in very specific scenarios. So let's see how that happens. So before we talk about that, we'll just discuss what I've just discussed in the previous slide already. That is, in addition to the two regulatory subsets that I had discussed last time in the context of skin, that is Th22 cells and Th17 cells, there are also just as a side note, I discussed interleukin 22 impairs epithelial barrier function, so that allows for little bit of that epithelial leakage of endoluminal peptides into the submucosa, or into the mucosa, resulting in prevention of unnecessary immune response. So that's what I meant by those ILC2 cells becoming protective there. Okay, now when you have TGF beta being produced by the tolerogenic CD103 positive and fascin positive dendritic cell, okay, that induces SMAD signaling like TGF beta does as in normal circumstances, inducing the expression of transcription factors FOXP3 and RUNX3 as I just discussed, and resulting in the production of T regulatory cells, okay, which then induce interleukin 10 and TGF beta. So this becomes a positive feedback loop, and therefore a population of T regulatory cells is maintained in a normal intestinal mucosa. Okay, so then why does IBD develop? So let's see what is happening in IBD. Now in IBD, essentially two rather interesting things might happen. Okay, so let's see what happens. One is that in some forms of IBD, there is increased permeability of the intestinal mucosal membrane, okay, mucosal layer. Now that increased permeability of intestinal mucosal of the intestinal mucosa results in proteins leaking in from in between the cells. And as I discussed earlier, that would result in, like in atopic dermatitis, in a runaway Th2 followed by Th22 polarization. Okay, which will cause more epithelial barrier dysfunction, which would again result in the same thing. So resulting in a Th2 polarized immune response that is primarily close to the surface of the mucosa, because obviously it is directed against proteins that are coming in through the in between the epithelial cells. On the other hand, the other thing that might happen is, we see, if you think about it critically, the oral tolerance is maintained by basically increasing the threshold for innate immune activation in the intestine. Okay, so say this is the normal threshold for, this is your basal inflammatory tone, this is your normal threshold for activation of innate immune cells. So DAMs and PAMPs, or damages to molecular patterns and pathogens molecular patterns, are produced due to some reason, and that causes innate immune activation. Okay, so this is the y-axis here is activation. Okay, now if it crosses this, there is an immune response ensues. Now essentially what that entire antigen processing pathway has done in the epithelial cell is that the epithelial cell innate immune activation only happens at a much higher level of or concentration of DAMPs and PAMPs. Okay, so that is what maintains oral tolerance. So how does that exactly work out? So what happens when that threshold is crossed? So once the threshold is crossed, what ends up happening is that surface TLRs on the epithelial cell, okay, specifically TLR4, TLR6 and 1, TLR1, 2, 2, 6 and TLR4 rather, okay, start activating NF-kappa B because they detect bacterial products. And our friend from the previous discussion, that is NOD2, also ends up activating NF-kappa. Now NF-kappa B in this particular cell causes activation of a particular caspase called an enzyme which is a caspase called caspase 1. Okay, now caspase 1 is the same enzyme that is activated downstream of inflammasomes, which we'll be discussing when we discuss monogenic autoinflammatory disorders and Behçet's. There's a connection there. If you know, you know. Okay, so that results in production of interleukin 1 beta, and that interleukin 1 beta in turn goes and is secreted by the cell and acts on the same cell. So it ends up activating its receptor, that is the interleukin 1 beta receptor 1. Okay, that induces a very specific miRNA production within the epithelial cell. That miRNA is an important miRNA to remember, that is MIR196. Okay, now that MIR196 is actually it is a small or it is a interferon RNA, as the name would suggest. Okay, it's a interfering RNA. So what it does is it goes and binds to the RNA of that is translated into a protein called IRGM. Okay, and these names are relevant because they are mutated in these disorders. So we'll see that mutations are involved these particular genes. And IRGM normally functions to inhibit that endosome followed by autophagy response that was maintaining the T regulatory cells at this site. So now what ends up happening is that the brakes are off. So the amount of antigen flux that is happening through this process suddenly increases a lot. Okay, so I told you that the low level of flux there was what is maintaining T regulatory cells. But now there is a lot of MHC class 2 expression on the cell surface. Okay, and a lot of that is getting presented to naive T cells or CD4 plus T cells. Now, in addition to that, as we just discussed, interleukin 1 beta is being produced, and interleukin 1 beta obviously is a pro-inflammatory cytokine, and that ends up activating newer naive T cells to non-T regulatory polarizations. Okay, so specifically Th17 and later Th1 polarization. Now, Th17 T cells in turn produce interleukin 17 as they normally do. Okay, and interleukin 23. Interleukin 23 acts on themselves and maintains their population. And this then ends up causing influx of a new type of dendritic cell, which is a CD163 plus expressing activated dendritic cell. Okay, that then produces more interleukins that cause a Th17 polarization and then a Th1 polarization. Okay, and similarly, there is influx your of a new type of innate lymphocyte type cell type 3, which then produces interleukin 23, which also again increases the polarization of T cells to Th17. So as you can see, essentially the immune system at this point has switched from a tolerogenic immune local epithelial immune system to a very non-tolerant immune system. Okay, and this switch is reminiscent of the switch that occurs in other places, but the threshold is much higher. Okay, so this happens only once there is very significant amount of damp or PAMP production at this site, and obviously this is required because of otherwise bacteria and pathogens would take advantage of this and start affecting or causing human diseases primarily, or any mammalian disease primarily through the intestinal tract, which to some extent they do. But yeah, okay, so this needs to be there. Okay, the threshold needs to be there. Now, very briefly, if in one sentence I was to describe the pathogenesis of Crohn's disease, all that is happening is that this threshold for innate immune activation is getting lowered. So even with normal commensal bacterial exposure, okay, the relatively lower amounts of pathogen associated molecular patterns that these bacteria produce, there is innate immune activation. Okay, now importantly, just like we saw with the skin, it's a chicken and egg situation. So epithelial barrier dysfunction causes Th2 polarization, as we discussed for atopic dermatitis there. Okay, here also it causes Th2 polarization. Similarly, this kind of inflammation in the epithelial the mucosa of the epithelium of in a patient with Crohn's disease also causes secondary damage to the epithelial lining and the mucosa. That also causes a breach in the normal mechanical barriers between the lumen of the intestine and the lumen of the intestine and the mucosa of the intestine. Okay, so that secondarily causes a skin barrier dysfunction. Okay, so intestinal bacterial dysfunction. So ulcerative colitis in that way is analogous to so ulcerative colitis in that way is analogous to atopic dermatitis. Okay, in that epithelial barrier dysfunction occurs first, and Crohn's disease in that way is analogous to technically Behçet's disease, and we have not discussed that. So okay, it's analogous to that. Okay, and psoriasis. Okay, yeah. So as I discussed before, there are both Th17 cells and Th22 cells produce interleukin 22. Okay, and interleukin 22 causes epithelial barrier dysfunction. So epithelial barrier dysfunction can cause inflammation in the mucosa of the intestine, and inflammation in the mucosa of the intestine can induce epithelial barrier dysfunction. So it becomes a runaway phenomenon, and that is why actually all of these disease entities then get clubbed under one broad heading, that is inflammatory bowel disease. Okay, but the phenotype varies, and we need to talk about that in detail. Okay, now here there is an important function that a new type of cell that I'm introducing for the first time. It's not that technically that new. So that is called the Th9 cell. Okay, so the Th9 cell is the primary cell that is involved in the pathogenesis of ulcerative colitis. Okay, so the Th9 cell is produced actually secondary to Th2 polarization. So as I discussed earlier, in ulcerative colitis there is a primary barrier dysfunction analogous to atopic dermatitis. So peptides within the lumen of the intestinal wall leak in between the cells, the epithelial cells, and these peptides are then they induce production of, as we discussed with atopic dermatitis, thymic stromal lymphopoietin. Okay, that thymic stromal lymphopoietin induces local naive T cells to undergo Th2 polarization. Now, any Th2 cell will then start producing uh, start producing certain cytokines, and we'll see what cytokines those are. So it produces interleukin 4, interleukin 5, and 13. So interleukin 4 induces local Th2 cells to, in addition to expressing, rather than expressing GATA3, to start expressing three other transcription factors, that is PU1, okay, BATF, and also a signaling molecule called IRF4. Now these cells are notorious for producing a very large amounts of interleukin 9. Okay, and interleukin 9, we'll see, has got very important roles in the pathogenesis of ulcerative colitis. Now, however, because there is no specific transcription factor that the cell has, a master transcription factor like a Th1 or Th2 or Th17 cells, whether or not it is reasonable to call them Th9 cells or they're just a subset of Th2 cells is a matter of debate. However, for clarity, I will call them Th9 cells. Okay. Now, the interleukin 9 that is then being produced actually enhances Th2 cell production of IL-3 and enhances Th2 cell production of IL-2, thus maintaining two things: the epithelial barrier dysfunction that is happening and the production of ILC2 cells, which are essentially innate lymphocyte 2 cells that mirror Th2 cells but don't require all of the intricate polarization that that happens there. Now in homeostasis, basically interleukin 9 also maintains T regulatory cell survival, but once the switch occurs, okay, I just discussed, from tolerogenic intestinal mucosa to a immune activated intestinal mucosa, there it perpetuates the inflammation, and so therefore it becomes very central to the pathogenesis of ulcerative colitis. Now, as you can see now, ulcerative colitis and Crohn's disease are actually two ends of the spectrum of inflammatory bowel disease, or broad heading of inflammatory bowel disease. So let's see what happens there. In ulcerative colitis, the first step is epithelial barrier dysfunction, like atopic dermatitis. Okay, so why does that happen? Now, in case of atopic dermatitis, that was because a particular protein called filaggrin was not had a functional problem in the skin. Similarly, in ulcerative colitis, it is because some other proteins that are important for maintenance of the barrier function, okay, called AGM, orozomucoid related, DL3, Xbox binding protein 1, and ECM1 are defective. Okay. Now, on the other hand, as I just discussed, Crohn's disease results from a decrease in the threshold for innate immune activation at the intestinal epithelium. So let's just have a look at what are the proteins that are or genes encoding proteins that are mutated in this regard. So the first gene that is there is IRGM. So if you recall from the initial discussion, this was your epithelial cell. The epithelial cell was endocytosing bacterial products, and that was using ATG16L1. Okay, these bacterial products ended up inside an endosome. Okay, and that endosome underwent autophagy and finally was expressed in the context of an MHC class 2 molecule, and that was then detected by T cells, which under normal low levels of this kind of flux underwent T regulatory polarization. Now IRGM was actually an inhibitor of this autophagy, and it was maintaining this flux at low levels. Okay, a low level of peptide or antigen flux was happening across the epithelial cells. However, if you have a loss of function mutation in IRGM, you don't really need IL-1 to be produced and that to then secondarily inhibit IRGM. IRGM is self-inhibited. Okay, so that as a result, the threshold for immune activation decreases. Similarly, if ATG16L1 is too good at its job, the flux will increase, again reducing the threshold for innate immune activation. Now, I discussed IL-1 was produced because NOD2 was getting activated by bacterial products. Now if NOD2 is again too good at its job, the same thing will happen. Okay, so you get the general gist of how these genetic polymorphisms result in a decrease in the innate immune threshold. Okay, so threshold for innate immune activation at the intestinal mucosal epithelium. Now there are four other genes involved, and they essentially function in very similar ways, the details of which are not very relevant. Okay, so I am not going to go into it right at the present moment. However, let's talk about let's talk about the second step. So now what happens is, in ulcerative colitis, see, we just discussed that a little bit of intercellular intra or transepithelial protein leak is normal. It happens. Okay, that perpetuates a Th2 polarization and then a secondarily a Th9 polarized response, and that maintains T regulatory cells. Okay, but in people who are genetically predisposed to ulcerative colitis, those T regulatory cells don't do their function properly. Okay, so they are not able to produce proper amounts of IL-6. So T regulatory cells dysfunction because of abnormalities in IL-6. And when we discuss your primary immunodeficiencies, we'll be discussing defects in T regulatory cell function. Okay, there are 4 different types of T regulatory cell functions that result in 4 broad categories of primary immunodeficiencies. 3 of them have prominent colitis, and that is ulcerative colitis. Okay, so you see the correction there. Okay, now on the other hand, once epithelial inflammation happens in Crohn's disease, that epithelial inflammation secondarily causes barrier dysfunction. Okay, so the same genes that were associated with ulcerative colitis are also associated with Crohn's disease, with the exception of ECM1. But that process is a secondary process. Okay, so it is only if the epithelium is damaged and the mucosa is damaged, that is when this becomes an issue. Now in step 3, in case of ulcerative colitis, you have a Th2 followed by Th9 polarization, which we've just discussed in great detail just in the previous slide. Okay, whereas in case of Crohn's disease, what you have is a Th1 or Th1 polarization or a Th17 polarization, to be more exact. And there are some polymorphisms that predispose to this. That is your TNF-AIP3, which is actually a negative regulator of TNF alpha signaling, and CCR6, which is the primary receptor that is expressed by these cells. So we've discussed 2, 4, and 6 are expressed by Th1 and Th17 cells. So as a result of that, Th1 and Th17 cells come into the picture. Okay, and followed by a prominent Th17 polarization. Now the thing with Th17 polarization here is, unlike in psoriasis versus atopic dermatitis, where it was psoriasis primarily as Th17 polarization and atopic dermatitis as Th2 polarization, it would seem that these two are mutually exclusive, but not per se. Okay, so we discussed that even in atopic dermatitis, over a period of time, because of that epithelial barrier dysfunction, secondarily you can get too much inflammation and secondary Th17 polarization, and vice versa also, because Th17 polarized neutrophil mediated epithelial damage can cause epithelial barrier dysfunction, and some T cells will then undergo Th2 polarization. Okay, so finally you have Th17 polarization in both disorders. Okay, and this is important. So both of them share polymorphisms in genes that would result in increased Th17 polarization. Okay, so what are those genes? The first gene is JAK2, second one is STAT3. Now just as a random fact that I'm throwing in here, STAT3 is the only STAT that is activated by all interleukins, the only and interferons, the only exception being interferon gamma. Okay, so every single interleukin activates STAT3. Okay, now then we have interleukin 12b, so interleukin 12b, then the interleukin 23 receptor, and it's not very difficult to understand why that would result in increase. This is a gain of function mutation. It activates, so Th17 cells don't have to produce as much interleukin 23 to activate themselves. Okay, and then finally a specific prostaglandin receptor, that is your prostaglandin E2 receptor type 4. Okay, so that is these are the 5 genes that are shared by the two diseases because both of them share Th17 polarization. Okay. Now, see, the other genes that are shared are epithelial barrier dysfunction. This what determines the exact phenotype is actually what is happening first, as in what is more prominent and therefore is happening first. Is it the epithelial barrier dysfunction that is the more prominent problem, or is it the decreased innate immune threshold that is a more prominent problem? And sometimes they are equal. Okay, so you can have colitis with features of both. Okay, so it is to be expected, and therefore biopsies that show features of one or the other are what are classically described, but in between is the norm. It is the literal norm. Okay. Finally, there can be polymorphisms in genes that result in increased neutrophil activation, and that again would cause neutrophil mediated inflammation. Okay, so just to reiterate, epithelial barrier dysfunction is the primary initiating insult in the pathogenesis of ulcerative colitis, whereas Crohn's disease results from a decreased innate immune activation threshold in the intestinal epithelium. Okay, now fine, but why is that such a big deal? Why make such a big deal out of this? What would appear as nitpicking? Why make it so such a big deal? So the thing is that the epithelial barrier dysfunction in ulcerative colitis and the decreased innate immune threshold in Crohn's disease result in two very specific disease distributions within the GI tract. Okay, and that is a big hoo-ha is made about all of that. I mean, a lot of attention is given to this type of polarization. There is an argument to be made for that, for validity of that also, but we'll discuss it. Okay, so let's see what happens. So this is two separate cut sections, cross sections through the intestine. Okay, now in the first situation you've got epithelial barrier dysfunction. Okay, the thing is, every single epithelial cell has these genetic polymorphisms that are resulting in barrier dysfunction. So the problem affects the entire mucosa contiguously. Okay, the second thing is the lumen, the Th2 polarization is in response to leakage of proteins into the intestinal or into the interstitium of the mucosa of the intestinal wall. So the inflammation also shows a gradient. So the maximum concentration will be here and least concentration will be here. So the maximum inflammation will be here, that is in the submucosal area, and that will progressively taper off or decrease in terms of intensity as you go towards the serosa. Interesting, right? Now on the other hand, when you have a Th17 polarization due to decreased innate immune threshold, the threshold, wherever the threshold is crossed, that is where you will have the inflammation. Okay, so another thing is, obviously this is a cross section of a longitudinal structure like this. Okay, and fecal matter or digested post small intestinal digested intestinal luminal contents are moving along the long axis of the intestine. Now the flow rates, however, are not the same everywhere. There is a little bit of stagnation. And where is the stagnation? Not at the center of the fluid pool that is there. So the stagnation is not the same. It's not in the middle of the lumen of the intestine. It's actually primarily at the sides of the lumen, or actually the base or the folds, the base of the folds of the intestine. Okay, so the fluid within the lumen is moving freely here, but it is stagnated here, and because it is stagnated there is bacterial proliferation there. Okay, and bacterial proliferation at these sites would therefore result in more innate immune activation at those specific sites, and we get involvement here, okay, so patchy involvement. But again, once inflammation ensues, the inflammation is not directly in response to the gradient of peptide leakage into the epithelium. Okay, it is primarily a self-perpetuated Th17 polarized response, so that tends to become transmural. Okay, so this is going to become transmural, and this will be primarily submucosal, okay, with a distinct gradient. And when you look at it otherwise superficially, there will be a contiguous involvement of the entire mucosal lining, whereas this will be a patchy involvement of the entire mucosal lining, reflecting the true in vivo folding of the intestinal epithelial mucosa. Now let's see what that will look like. So in case of ulcerative colitis, the epithelial barrier dysfunction affects the entire epithelium, as I've just discussed, and that is contiguously. So you end up getting this kind of diffuse involvement without any areas of sparing in between. And as the disease progresses, the involvement progresses. Again, contiguously. There are no spares, there is no intestinal sparing in between. Okay. Now, I have shown it from the rectal end going to the cecal end. Okay, but the reverse can also happen. Okay, because there are two parts of the large intestine where there is fecal storage. One is the cecum and the other one is the rectosegment. Those are the parts that are bulbous and large in size. So so it is those two sites that are, broadly speaking, the sites where intestinal Th2 polarization and then Th9 polarization is likely to happen in ulcerative colitis. Okay, so those are the two most common sites. Now here I'm just showing the same thing but in a real life colonoscopy view. So what do you see? You see this kind of inflamed friable mucosa, almost fully almost contiguous with each other. Okay, I can essentially draw out the mucosa that is inflamed. Okay, so it's forming a broad patch. There is some mucosal sparing, but it's not very prominent, and actually that's probably not even sparing. Okay, so this is your ulcerative colitis, and like I said, it is the distribution is such because the initiating problem is primarily a intestinal epithelial barrier dysfunction. On the other hand, as innate immune activation threshold is reduced in Crohn's disease, and therefore there is primarily an innate immune activation in Crohn's disease. Innate immune activation mirrors the local distribution of bacterial products, the concentration of bacterial products, and therefore follows the depths of the mucosal folds. So see, these are the folds. Okay, these are the folds of the mucosa, and therefore it is these areas that are going to get affected. Now this is a cross section. When I take the intestine out and I lay it flat on a table or something, I will find these small ulcers. Okay, and these look like aphthous ulcers in the oral mucosa, so they're called aphthous ulcers. Okay, and that then results in the folds fusing with each other, producing this serpentine or serpentinous pattern. Okay, with areas of completely spared mucosa in between, and this is what you see in patients with Crohn's disease. Now this could affect literally any part of the GI tract. Obviously the colorectal sigmoid would get affected maximally. Okay, but just so because of the distribution of the immune system of the intestinal tract, it primarily affects the ileum. Okay, so that is where you get most of the involvement, and that is followed later by the rectosigmoid, but it reflects essentially the normal distribution of innate immune activation or innate immune thresholds within the intestine. So they are usually lowest in the ileum and the rectosigmoid, and that is where primarily bacterial pathogens are controlled. So that is where Crohn's disease also develops. Okay, so this is the same thing, but I'm going to show you something very interesting. I'm going to show you the clinical colonoscopic findings. So as you can see here, this is relatively normal looking mucosa, but what do you find here? You find these ulcers in the mucosal wall. Okay, and these are patchy ulcers, essentially actually following one mucosal fold, but they have not yet to fuse with each other. So let's see what it looks like when they start to fuse with each other. See, now these ulcers, these were ulcers along one mucosal fold, and these have not fused, but these ulcers have fused. Okay, producing a serpentinous pattern. And if we take that process and we extend it continuously, then what ends up happening is that the serpentinous ulcers fuse together so much that most of the mucosa is now ulcerated, and there are these islands of sparing in between. Okay, these islands of sparing, I think I should use a black marker. So these islands are sparing in between, okay, with ulcers, serpentinous ulcers in between like this. These are the ulcers, and then there are these islands of sparing, and this essentially looks like a cobblestone street. So these are the polygons are the spared mucosa, and the ulcers are essentially going in between them. So this would be the ulcers, and these are the normal mucosa, okay, and that is the cobblestoning that you end up getting with ulcerative colitis, with Crohn's disease. And now let's deduce the clinical presentation that would happen. So the clinical presentation would depend on what? It would depend on what site in the intestinal tract is affected, because the different parts of the intestinal tract have different, slightly overlapping but primarily quite specific functions, okay. For example, the small intestine is primarily involved in absorption, and the large intestine acts as a storehouse of feculent matter, and during that storage process also reabsorbs water from the feces, making it solid. And also the large intestine and the terminal ileum and the large intestine actually function as immune sentinels. That is where the most of the immune system of the intestine is located, okay. So when you have acute disease, as you discussed in ulcerative colitis, because there is an epithelial barrier dysfunction, there is Th2 polarization, okay. Because of that, we get contiguous mucosal ulceration primarily right next to the epithelial lining, okay. So it is primarily mucosa, very superficial mucosa, that is affected, okay. In case of Crohn's disease, we get in the threshold for renin activation is decreased, and that threshold results in Th17 polarization and secondary neutrophil mediated damage, resulting in those aphthous ulcers that became serpentinous ulcers, which became cobblestone, as we've just seen. When the disease becomes a little chronic, you end up having M2 macrophage formation, and that can damage the myenteric plexus, okay, and this becomes clinically relevant later, and this will result in initial mucosal atrophy, wall thinning, okay, and over a period of time dysplasia, metaplasia, and because when there is damage to the myenteric plexus, something known as a toxic megacolon, that is the myenteric plexus is what is responsible for normal peristalsis. So the intestine or large intestine stops contracting and having normal peristalsis and just dilates, okay. Now Th1 polarization occurs in case of long-standing Crohn's disease, resulting in loose non-caseating granuloma formation. That is something defined in biopsy, and since the process is transmural, okay, it is to form the mucosa right till the serosa, there can be fistula formation. A fistula is a tract that is connecting to epithelial linings, okay. So in this case, the epithelial linings on one side is the epithelium of the intestine, and on the other side it is the mesothelial lining, right, okay. It could also be the other epithelial lining could be the bladder lumen, okay. So there could be a bladder fistula, okay, or the ureteric lining, or even the uterine lining, okay. So anatomically contiguous structures. Now also there is that the inflammatory milieu that is being produced causes a fat cell or adipocyte hyperplasia in the serosa, and that adipocyte hyperplasia in the serosa results in increased number of adipocytes in the mesentery of the right next to the sites of inflammation, and that is descriptively given the term creeping fat, okay. Then over a long period of time, as we've just discussed for the ulcerative colitis, also there is metaplasia, and intestinal metaplasia eventually can result in malignancy in both cases, okay. However, fibrosis and stricture formation happens only with Crohn's disease because of the transmural involvement that is there, okay. But like I said, these are two ends of a spectrum, okay. So that is something that you need to understand. So let's see what the clinical features are. So what is the most common site of involvement of ulcerative colitis? Naturally, it is the rectosigmoid, okay. We've discussed why. Single site is the rectum, and when the rectum has this kind of superficial mucosal swelling, edema, or inflammation, there is swelling, there is mucosal edema, so the patient starts developing rectal symptoms, what are called rectal symptoms. So what are the rectal symptoms? Essentially, the patient will pass mucus and stool, okay. The stool will not be hard, because for stool to become solid, water has to be reabsorbed, and for that there has to be normal intestinal epithelium. That epithelium is now inflamed, okay, it is not functioning properly, so it is semi-solid stool mixed with mucus, okay. and once the person passes stool, the mucosal lining is edematous and patulous, so it activates the nerve fibers that are there in the lumen and in the wall of the intestine, and that gives the patient the apparent feeling that after passing stool also there is some stool pending inside the rectum. So that is what we call tenesmus. Okay, so these are the symptoms that you get. Now on the other hand, in case of Crohn's disease, on the other hand, in case of Crohn's disease, we have involvement of both the ileum and the large intestine, but most commonly the ileum. And again, this represents the distribution of the immune system within the intestinal tract. Okay, so what are the most common clinical presentations? Therefore, that is, as I just discussed for Crohn's disease, that would be perrectal bleeding associated with tenesmus. So once the inflammation becomes too much, there's neurovascularization, the vessels are not very well formed, they bleed. Okay, so that's why bleeding is there, and mucus formation with semi-solid stools. Whereas in Crohn's disease, the primary problem is in small intestine, so in ileum. So it is ileal absorption that becomes a problem, and you get malabsorption related problems. Okay, and this is a type of diarrhea, and we'll be coming to the exact physiological outcomes of this in the third discussion in this series. Okay, then the site that is not affected by by ulcerative colitis is that site where there are no intestinal luminal bacteria that can cause leakage into the through the epithelial lining. So that site would obviously be the small intestine. Okay, so the small intestine is spared. Whereas in case of Crohn's disease, what is spared is typically the rectum. Okay, the rectum is not affected. So again, reflecting the distribution of the immune system within the intestinal wall. Okay. Now, what are the complications? One, I just said M2 polarized macrophages can cause mesenteric plexus damage, and that can cause toxic megaclorin. Again, depending on the site of involvement in Crohn's disease, you could have malabsorption. Okay, you could have either fistula formation, that is, various epithelial tracts getting connected to each other because of the transmural nature of the disease. You could have stricture formation, the fibrosis causing the lumen of the intestine to become smaller in size. Okay, and in both cases you could have malignancy. Okay, and that we've gone through in the previous slide. Now, the risk factors for malignancy, there are some that are common. Okay, so the longer the duration of disease, more the inflammation, more the time for metaplastic changes and dysplastic changes to occur. Okay, more extensive the disease, more number of cells are affected by this metaplastic or dysplastic cells, therefore more likely it is. The presence of colonic strictures occurs more commonly with Crohn's disease, but especially if it is occurring with ulcerative colitis, I told you there is spectrum, so that can happen in both, is something that is very important, and that increases the risk of this. And extraintestinal finding, that is primary sclerosing cholangitis, likely reflecting the high amount of disease activity at an immunological level, is also a risk factor. Now there are two risk factors that are independent. Okay, so in ulcerative colitis, the presence of pseudopolyps. Okay, pseudopolyps are the areas of mucosa that have been spared from the inflammation. As I told you, that doesn't typically happen with ulcerative colitis. When it does happen, okay, those pseudopolyps could actually truly be metaplastic or dysplastic malignancies, epithelium that has become malignant. Okay, and so therefore that would increase the possibility of it being a malignancy. And in case of Crohn's disease, if there is an enteroenteric fistula, or say there is a jejunocolic fistula, okay, between the jejunal loops and the colon, say the transverse colon, there is a fistula. Okay, so this part of the colon is no longer being used for passage of fecal matter. So that area, actually, practically speaking, becomes difficult to assess on colonoscopy, and therefore any pre-malignant lesions developing in that area can get missed. Therefore it becomes a risk factor in epidemiological studies. Strictly speaking, these are the 4 risk factors. Okay, these 2 are primarily result of the way we detect malignancies. Okay, now see, these are auto-inflammatory disorders, not autoimmune disorders. So why the emphasis on serologies? So actually, serologies are not useful for diagnosis, and the only reason that serology is considered in these discussions is because of a lack of understanding of how these are autoinflammatory disorders and not autoimmune disorders. Okay. However, the thing is that the intestinal microbiota within the human colon is relatively specific or relatively well preserved within our species, and therefore the antibodies that develop are against those specific bacteria, and they tend to okay, these are not part of the pathogenesis of the disease. This is just a parallel process that is just by chance happening. And in the past, we used to identify autoimmunity by detecting antibodies. So this is the result of that. Okay. So with ulcerative colitis, two-thirds of patients often have a type of P ANCA positivity called atypical P ANCA, and we'll discuss what this is. This obviously reflects how severe the disease. The more severe the disease is, the more the patient is likely to have this, and vice versa. So it's a marker of disease severity. They also have anti-Saccharomyces cerevisiae, okay, which is a yeast, antibodies, okay, in 10% cases. Now the pattern is exactly the reverse in Crohn's disease. So atypical P-ANCA is only present in 10% of Crohn's disease, and ASCA or anti-Saccharomyces cerevisiae antibodies are present in two-thirds of patients with Crohn's disease. See, again, these are just two ends of a spectrum. So this is why they mirror each other so much. Okay. Now the thing is, there are some antibodies that have been described in Crohn's disease that indicate the specific disease subtype. Okay, so this likely represents the pathogen responding to the changes in the human immune system, and then secondarily inducing complications. Okay, so it's very easy. I2 antibodies are again specifically a protein that is present. These are all proteins that are present in gram-negative bacteria, flagella, or cell wall. Okay, so see how I use a memory trick here. I looks like essentially two parts of the intestine. The intervening portion has become stenosis. So anti-I2 antibodies correlate with stenosis. Okay, because this looks like a stenosis. Now OMPC is associated, anti-OMPC is associated with perforation. Okay, and anti-CBR is associated with stenosis and perforation. Okay, so these are the three antibodies. Again, factual questions are the norm in medical examinations, so it's something that you may need to remember. Okay, now just very briefly, the extraintestinal manifestations of inflammatory bowel disease are the result of three mechanisms. One is extension of the intestinal immune process. Okay, this is technically an autoinflammatory, not an autoimmune process. So this is autoinflammatory. Okay. Now the second is development of a autoinflammatory process that shares common genetics with IBD. The classical example of this is axial SPA or ankylosing spondylitis. Okay, and we'll be getting into this in our next discussion on extraintestinal manifestation. And finally, it can be due to malabsorption, and obviously malabsorption will occur because absorption occurs in the small intestine, so it will occur in Crohn's disease, because Crohn's disease is the one that can affect the small intestine. Okay, so again, extension of intestinal immune processes to other tissues can happen with either ulcerative colitis or Crohn's disease. Development of autoimmune diseases that share common genetics with IBD can again happen with both ulcerative colitis or Crohn's disease. Malabsorption primarily is much more common with Crohn's disease. However, see, these two are more common in Crohn's disease, because in Crohn's disease the immune dysfunction is not due to epithelial barrier dysfunction. So for that type of immune dysfunction to leave the intestinal wall and go somewhere else, it is much more marketable in a way. Okay, whereas for other tissues to get affected by the same type of pathogenesis as Crohn's disease, those tissues would have to be barrier tissues. Okay, and different barrier tissues like skin or the barrier tissues within the lungs, they are the mechanical proteins, or the mechanical barrier is maintained by a different set of proteins. Okay, like for example filaggrin in case of skin, Okay, and we'll discuss later DPP10 and all in case of the lumen of the respiratory tract. So see, the mutations that cause barrier dysfunction in case of ulcerative colitis are not going to have the same effect at other barriers. So as a result, extra intestinal or non-intestinal involvement would be much less likely in case of ulcerative colitis. Okay, now yeah, so whereas in case of Crohn's disease, Th17 polarization happens, and then Th17 polarization is it's a universal thing. It happens throughout the body, so it can affect other organs much more commonly. Now, just a brief discussion on the risk factors of inflammatory bowel disease. So, as we've discussed, see, as the immune system develops, intestinal pathogen exposure causes that initial Th2 polarization, because the intestinal lumen is the epithelial lining is intact in a normal person. Okay, and there is some leakage of proteins through it. Okay, and that induces thymic stromal lymphopoietin production and Th2 polarization. And as the child grows, or as a child, human baby or human child grows, there is exposure to bacteria. Okay, primarily acquired from the mother. Okay, and that induces some degree of Th1 and Th17 polarization, and essentially a normal immune system, it gets stuck in between. Okay, and is primarily T regulatory cell polarized, maintaining oral tolerance. Okay, now if that it is polarized to Th2, you get an ulcerative colitis like problem, and if it is excessively polarized to Th1 or Th17, you get a Crohn's disease like problem. Okay, so some environmental exposures can predispose to one or the other. Okay, the best example of this that I can think of is, okay, so we'll discuss the first thing. So see, as I discussed, it is the appendix and in the ileum that is the primary site of the immune system of the intestinal tract. Okay, and the appendix is where the naive T cells that will cause this kind of Th2 polarization arise. Okay, so if you remove this appendix in an appendicectomy, you end up causing you can avoid this kind of Th2 bias, and therefore ulcerative colitis risk will decrease. Okay, next, see, smoking produces reactive oxygen species. Reactive oxygen species activate the innate immune system. Okay, now innate immune system activation is the first step of Crohn's disease, so it will naturally increase the risk of developing Crohn's disease. It doesn't really increase, or rather in epidemiological studies is protective for ulcerative colitis. Okay, so because baseline immune tone actually steps up the barrier function and can slightly avoid the type of epithelial barrier dysfunction that normally results in ulcerative colitis. This is the likely explanation, but obviously I can't back this with data. But epidemiologically speaking, definitely smoking exposure does inhibit the risk or decrease the risk of developing ulcerative colitis. Now, the third situation is if you give the child antibiotics, and this is in the first year of life, within 1 year of birth. So this is when the child is receiving their colonic microbiota from their mother. Okay, so what happens is these antibiotics will kill off. Yeah, so these antibiotics will kill off the normal gut microbiota, okay, and pathogens. Okay, so if they kill off normal gut microbiota, as a result of that, you will have a persistent Th2 bias. So therefore an increased risk of ulcerative colitis. Okay. Whereas if there is exposure to certain pathogens during early childhood, that theoretically can increase the risk of this excessive Th1 or Th17 polarization, and that results in your increased risk of Crohn's disease. Now, oral contraceptive pill usage and low levels of estrogen and progesterone actually increase T cell survival, so that can increase the risk of, at least epidemiological studies say, Crohn's disease. Probably the same effect is there with with ulcerative colitis, but Th2 cells don't really require estrogen and progesterone as much as Th1 and Th17 cells do. Okay, so this is the general explanation for the risk factors, and I've summarized the risk factors again in a tabular form here. Okay, smoking, as I've just discussed, decreases risk of ulcerative colitis, increases risk of Crohn's disease. Why? Please think about it. It's because Crohn's disease primarily is mediated. The first problem is a reduced innate immune threshold. Okay, appendicectomy essentially removes the naive T cells that would have populated the intestinal mucosa. So those then there cannot undergo Th2 polarization, and therefore that decreases risk of ulcerative colitis. It has no effect on Crohn's disease risk. Okay. Antibiotics exposure at less than 1 year of age increases risk of all types of IBD, and this is the only risk factor that increases risk of both types of IBD. That's making it a case for frugal uses of antibiotics in infants. Okay, oral contraceptive pills increase survival of Th1 and Th17 cells, therefore they increase risk of Crohn's disease. Exposure to pathogens increases risk of Crohn's disease because it enhances Th1 polarization and Th17 polarization. Alpha methyl dopa, we'll discuss this in our discussion on SLE, essentially results in hypomethylation of T cells, resulting in increased tendency for T cells to undergo Th2 polarization or any type of polarization, but obviously the natural polarization of T cells is Th2, so therefore it increases the risk of ulcerative colitis in epidemiological studies. Finally, what are those pathogens? Okay, so there are three pathogens that have been found to be correlated in epidemiological studies. That is your M. pseudotuberculosis, E. coli, and Pseudomonas. Okay, and H. pylori is actually decreased. So with the decreased risk of inflammatory bowel disease, that could just be an epidemiological, fallacy, because H. pylori infections are so common. Okay, there's also a reduced risk of childhood asthma and CAD. So correlation doesn't equal causation. So I would take this with a pinch of salt. But this is again, as always, a factual question that is asked in our medical entrance exams. Okay, too much to my chagrin. There are some monogenic disorders also that are associated with IBD. That is, ulcerative colitis is associated with Scott-Eldridge syndrome and IPEX, whereas Hermansky-Pudlak syndrome increases the risk of Crohn's disease. And Turner's, there's increase in risk of both. Now, these two entities I will be discussing in primary immunodeficiencies, and you'll understand that with Scott-Eldridge syndrome there is an increased Th2 polarization because T cells can no longer interact. They cannot form what is called an immune synapse with antigen presenting cells. So IPEX is a specific problem with development of T regulatory cells, and we've discussed how T regulatory cells are important for production of interleukin 10 and maintenance of oral tolerance. So there is a reduction in oral tolerance, and there's therefore secondary ulcerative colitis. Hermansky-Pudlak and Turner's I will discuss specifically when we discuss defects in innate immune functioning at a later date. Now, finally, there is one more bonus topic, that is there is one more topic, that is your we've discussed inflammatory bowel disease. Okay, why is it essentially the only cause of true cause of this chronic inflammatory diarrhea, excluding tuberculosis? We know the why now. What determines the observable patterns of IBD? That is also something that we have discussed. Okay, I hope that is clear now. In case of ulcerative colitis, is because it starts with epithelial barrier dysfunction. In case of Crohn's disease, it is because there is a decrease in innate immune activation threshold. We've also discussed how these problems and the location of these problems results in very specific perturbations in normal physiology. So ulcerative colitis primarily presents with rectosigmoidal inflammation resulting in rectal symptoms, passage of semi-solid stools with mucus, with blood. And Crohn's disease primarily affects the ileum and therefore causes malabsorption. Okay. Then we've discussed that yes, these processes can exist outside of the intestinal lumen or mucosa also, and we've seen there are three mechanisms for that, and those three mechanisms we'll delve into in the next discussion in the series. And we've discussed what are the external risk factors that predispose to one or the other type of polarization, and however they are different for ulcerative colitis and Crohn's disease. So there's one more bonus topic, that is pregnancy and inflammatory bowel disease. So pregnancy, so whenever we talk about pregnancy and any systemic disorder, we talk about how pregnancy affects the disorder and how the disorder affects pregnancy. So what is the effect of pregnancy on IBD? Essentially, in the first trimester, okay, ulcerative colitis can exacerbate, okay, and in Crohn's disease the exacerbation has been epidemiologically linked to the second and third trimesters. Now again, like I said, progesterone and estrogen increase Th1 and Th17 cell polarization and survival. So that may be the reason for this. As you, obviously the pregnancy progresses, progesterone levels skyrocket. Okay, so that was the probable explanation. Now again, like in all autoimmune autoinflammatory disorders, the general dictum is that prior to conception, the lady should be in remission. The intestinal disease should be in remission for at least 6 months. Okay, more than 6 months. Now, the effect of IBD on pregnancy on is one, fertility rates are normal except in two specific scenarios. Okay, so sulfasalazine exposure, which is the drug that we use for management, in males decreases male fertility. It causes oligospermia and doesn't really reverse significantly once you stop sulfasalazine. The other issue that arises is in women who have undergone colectomy, okay, followed by an ilioanal anastomosis, there has been an epidemiologically demonstrated decrease in fertility rates. So in females who undergone colectomy and have an ilioanal anastomosis, there's likely a lot of pelvic inflammation that results in decreased fertility rates. Importantly, during pregnancy, the intestinal disease activity rates are directly proportional to or inversely proportional to fetal outcomes. So in control of disease activity is highly important. So that brings us to the end of our discussion on inflammatory bowel disease. I hope the analogy with atopic dermatitis in the skin and psoriasis in the skin is apparent and quite clear. And I hope the reduction of the clinical manifestations is clear. In our next discussion, we'll be going into details about the extraintestinal manifestations of IBD in this series, and then we'll use this understanding to derive diagnostic frameworks for chronic diarrhea, starting with chronic inflammatory diarrhea. So thank you, and I'll see you in the next